Good morning. My name is Cristina López Espada. I am a vascular surgeon, which means something important to say at the beginning of the talk. And I need to thank Dr. Ibeas and Dr. Rocatey to kindly invite me to come here to talk about grafts. When they phoned me to tell me we want to invite you to come and talk about grafts, I said, okay, but what should I say? Because if you see in the next talks, Dr. Gilbert and Dr. Nadelao, they are going to talk about the new devices, the early graft cannulation devices, and about the hero devices. And at 12:15, Dr. Merino is going to talk about surveillance of grafts. So thinking about that, I was saying, what should I say then if everyone is going to talk about the main things about grafts, surveillance and new devices? So it took me 2-3 days to come to this talk and try to give you what I would like to hear if I was sitting where you are. So the main thing in this talk is graft indications. So when I'm going to operate it on a patient, I always have in my mind this phrase, which say, the ideal arteriovenous fistula is that one with give the patient a correct dialysis, with the longest permeability, and with the lowest complication rates. So that's the ideal one. So everyone has now on their head that the winner in that one is the AV native fistula. So the first surgical option should be an autologous fistula. So that's the problem, because I am, as we say in Spanish, dancing with the second verse, because it's not the worst. So I have to try to sell you or try to convince you that grafts have also a paper or something to do with dialysis. So if you see, everyone will have chosen to do a AV native fistula, and the grafts will left in the second place. So the next thing is to think, why is that? Why, what's the matter? Why we do not perform a graft in the first place? Why is that? So that's the main question. Is that a matter of patency? Is the main question that why we do not choose that one in the first step? But if we analyze the first question, could we take us to the wrong side? Because if we answer and we perform a fistula, the primary fail rate is higher for native fistula, which means that if we perform a fistula, it could fail more if we do a native than if we do a graft, which means that the rate of primary fail is 5 to 30% primary fail for native fistula and is lower for grafts, which is good. So I will say that is a good option because it gives me a fistula which works very quickly. But that is not the matter, because this is an important point, but it's not the point that the patient needs something more. What is the next step? Is this a matter of permeability? Yes, it is. Because if we analyze in the long term, the primary patency is always better for native or autologous fistula, better than any other graft. If we analyze from the beginning in 6 months permeability, the native fistula has a permeability of 72%, which is only 58% for grafts. So that is not really good. If we analyze the longest period, we have 18 months, which again is 51% for native fistula and 33% for grafts. And if we have secondary patency, is also worst for grafts. So now we have the main reason, or one of the main reasons why we don't choose grafts for patients as the first option, which means that is why our grafts are not the winner. The second question is, it is a matter of complications, because we have started this talk saying that we have a fistula with low complications and long permeability. So grafts have also problems with complications. Which complications? If we read through the literature, we know that hospital admission is higher for a patient who has been operated on a graft. We also know that the mortality rate is also higher, between 18 and 53% for grafts or catheters, which means that someone who is going to be operated on a graft are going to have more complications than if we do a native fistula. It's also a matter, very important one, a matter of infections, because we know that autologous AEF or VF have lower infection rates, and also the rates for reoperations are also lower for native or autologous fistula. So we have now the second reason why, unfortunately, if I am here, I'm not the winner. I am the second one on the round. So after that, I'm saying, okay, we are not going to do a graft unless we have this condition. So which are the conditions or the indications why we should do a graft? Because grafts are done, patients are operated on a graft, so when do we perform a graft? So based on the literature or in the evidence, we know that graft should perform in patients without forearm or upper arm veins, or because they have already used or they have failed. This is the main indication for grafts. The second one could be discussed, but it's also a reason, which is someone who required urgent dialysis and are not suitable for permanent central catheters. And the third indication that has been published in the guidelines are patients with chronic renal failure and short life expectancies of life. Okay, so these are the three indications where the grafts are the winners. So, but everyone needs to think that we have already talked, or the previous talker has talked about teamwork, because the indication for grafts is not only based on these three indications. We need to talk with the nephrologist, we need to talk with the patient, and we need to explore the patient with a clinical examination. We need to know where or who or which previous vascular access the patient had, the age, the comorbidity, and the urgency to put the patient in dialysis, which means if we want to choose a graft, we need to keep in mind all these indications, but we need to see the patient and decide based on which type of patient and which are the comorbidities. So there is no one clear indication for each patient, so one needs to individualize the treatment. So the second part of my talk should be about procedures. So now we have decided that we have the correct patient who needs a graft. So we have indicated the graft on him or her, and then we are going to perform it. So as I'm a vascular surgeon, that's a difficult answer, because we need to think about that very deeply. We need to think, what option do we have? So I'm going to give you just 3 or 4 quickly indications or preconditions that all surgeons have in head when thinking about a graft. First of all, we need to look for the arterial anastomosis to be the bigger that we have. The venous anastomosis needs to be as proximal as possible to have the higher flow. And the most suitable material is PTF, because based on literature, the long-term results of the PTF material is better than Dacron. The second thing that we had in mind is always the diameter of the graft, which has to be between 6 and 8 millimeters, and the length of the graft, it has to be between 20 and 40 centimeters. So everyone knows that, and the anastomosis has to be end to terminal, so end to lateral or terminal to lateral anastomosis, and here are the options. Everyone knows that the graft could be straight or curved, and there is no statistical differences between permeability of these two types of grafts. The second decision that one has to do is not just curved or rect, or it has to be, where do I have to do the graft? That's why the mapping, the ultrasound scan, or clinical examination give us the option that we can choose. It could be between the radial artery and the veins in the elbow, or could be as a loop between the brachial artery and veins in the elbow. The most frequently graft performed is the brachial axillary bypass, which is performed in the arm, as you know. But here is the next question. The third one is that we all know that upper arm grafts should be first done than lower limb or thorax grafts. There are very different options, very unusual grafts that can also be done, and they are technically more difficult for surgeons. This could be one option between the artery, the axillary artery and the axillary vein or the humeral vein. Could be if we have a stop or a thrombus in the subclavian vein, maybe we can think about doing an fistula or a graft between the brachial arterial and the jugular vein, as you can see in the image. We can also do a necklace graft between the subclavian artery and the subclavian vein. Also, there are many other options between the subclavian artery and the iliac vein, or the subclavian artery and the cava veins. So, what do we think about all this? Why don't we don't perform this type of grafts frequently? That's the second question. Why don't we try, or do we avoid as surgeons to try to do these options? First of all, because they are technically more demanding. We need to do the access of the artery or the veins are more difficult. And the main reason is because of graft infections and permeability also. There are also someone later is going to explain, there are new devices like the HERO outflow between graft and central venous catheter, and there are also grafts that can be punctured very early. So there are also unusual bypasses that can be done or performed in the legs, like between the superficial femoral artery and the common femoral vein or the saphenous vein, or also an axillary popliteal bypass, which is very, very unusual. So if you see from the literature, the answer is why don't we perform this type of grafts? Is because although the permeability is very similar between upper limbs grafts and lower limbs grafts, the problem is with the infection. The rate of infection in lower limb grafts is higher than upper limbs grafts, which means, or which make us not to choose that one at the first option. And the last question I'm going to talk about is something that a little bit later another talker is going to talk about, is grafts in the elderly. Why do we say about that? It's because everyone who is going to operate on someone who is older than 80 thinks grafts has advantages that are very useful for elderly patients, which is our patients who have not veins, our patients who have a very short life expectancy of life, and also they can be used soon. We don't need to wait for them to mature. And the last point is that they have a very low primary fail. So grafts are a very good option, or could be a very good option for someone who is older. So, but that is one good thing. But the other thing is that they are also disadvantages for these old fragile patients, because they have a very high rate of infection and also a very high rate of reintervention for a patient who is not very fit for 2 or 3 reoperations to repair a graft. So the decision is very difficult, but grafts is something that we need to keep in mind when thinking of operating on a patient with more than 80 years old. There is also a meta-analysis thinking of or analyzing the outcome in this patient, and they suggest that we should avoid fistula on the wrist. We should choose a native or autologous fistula also in the elderly, but in the elbow, and to avoid to try to do fistula in the breast and to choose a native fistula in the elbow. That's for elderly patients. But after that, grafts could be a good option for them. That's all. Thank you very much.